This course is designed to teach a delivery format for the Triple P Parenting Assessment. The process includes the use of various interviews, observations, and instruments such as the SDQ, CBQ, and PS. The course will follow a simple 10-step process of delivery and discussion. Please refer to the Triple P training course for more details. In this course, you will first learn how to conduct a Triple P parenting assessment to fidelity. You will then also learn how to defend, deliver, decode, and discuss assessment measures. A few things to do during this course is to follow along the corresponding instruments, increase the video speed under settings, pause the video, or take notes for the post-exam. During this course, we will follow a fictitious but true, names are changed, story of John and his two children, Faith and Mark. John was introduced to our services in a split home. He had 50% custody and the biological mother had 50% custody. You will see from their story how they scored on different measures through this assessment process. Triple P is about positive parenting practices. It's one of the most effective evidence-based parenting programs in the world. Triple P gives simple and practical strategies to help parents build strong, healthy relationships, confidently manage their children's behavior, and prevent problems developing. Triple P is used in more than 30 countries. According to the California Evidence-Based Clearinghouse, or the CEBC, Triple P is rated in number 1, meaning well supported by research evidence for disruptive behavior treatment. And it's also rated in number 1 in parent training programs that address behavior problems in children and adolescents. For today's training, we will look at 2 specific different levels of Triple P. The first is Triple P Standard, working with elementary age, and Triple P Teen, of course, working with youth. The times to use this assessment would be pretty much any case when Triple P is used. You use this parenting assessment at the beginning and also at the end. And then another time would be when DCS, probation, or court request a parenting assessment. You would know this either from the referral or by viewing the DCS IA or informal adjustment plan. Here's an example of one. At the top, you can see the parenting assessment is highlighted. That is them asking for this specific parenting assessment, or I should say a parenting assessment. The parenting assessment delivery format has been divided into different booklets now. There's a child booklet, which is used for each child involved with the parenting assessment or within the home. There's a teen booklet for every youth that is within the home. There's a parenting booklet that's used for each caregiver within the home. This could be also grandparents as well. And then there's this sample of a data summary. Now with the Triple P parenting assessment, you will submit only 2 different documents to DCS or probation. You'll submit the data summary booklet 1 from the beginning and the data summary booklet 2, which looks exact same. It just says number 2. The data summary booklet has all that you need in it. It has the interviews, it has the interaction observation, and it has the scoring sections for each of the scale or each of the measures that was used. So it has the parent interview, which we will look at today. It has the teacher interview, which we will look at in today's training. It also has the child interview or the youth interview, or I should say teen interview. The parenting assessment is divided up into various different parts. Actually, you might call them steps. These are the following steps. There's first a parent interview, then formulating the target behaviors, a teacher interview, assessment booklets, a child-teen interview, the scoring of the measures, the parent-child-teen interaction observation, then confirming the data with the supervisor just before presenting that data to the parent, and then ongoing would be updating the target behaviors. Next, we're going to start with Step 1, which is the parent interview. The parent interview looks like this, and it's within the data summary booklet. It is generally a breakdown of the parent's concerns about behaviors, factors influencing behaviors, and obstacles to change. There are 7 to 8 sections within the parent interview form. The first section is those family details, which creates a systems view of the home. The second is previous diagnostic information that's been used to describe the child and teen's behavior. And then the third is straight up the child teen's behavior, which might include the what, the when, the how long, how often, the impact on the family, and the attempts to solve. The next is the factors influencing the child teen behavior, such as the developmental history, particularly from birth to present, education, school, testing, assistance. Other sections might include specific obstacles to change that the parent may be aware of. Could be circumstances, maybe grandfather just passed away who is highly looked up at by the youth. Could be a parent adjustment as well. That could be a health an obstacle. And then the health status of the individuals within the home is important. We're going to get some of that from the comprehensive assessment, but in light of the parenting assessment and that relationship is what we're looking at there. And then last but not least would be the parent's perceptions of the problem. And associated with that would then be not forgetting to ask, and it's not listed on here, but what's the parent's expectations about this parenting program? And that might be something very important to look at before you begin jumping in. What do they hope to get out of this parenting program? There's a couple interviewing tips with parents that I'll say are do's, and then there's a few that are don'ts. Do's, the first would be setting up the interview guidelines beforehand, providing general topics of what will be covered, the content, and the time it might take. Asking open-ended questions, gently guiding the parent back to the form and the questions to stay on track, and then introducing behavior monitoring right within this session. Right within session 1, making sure we introduce how to track those behaviors that the parent wants to see decrease, but also the behaviors that the parent wants to increase. A few don'ts might be: don't interview the parent in front of the children or the youth. Don't provide advice without asking or gaining permission. That's MI 101. And don't make accusations about the parent's poor parenting. Instead, use the Triple P format to produce that data and present that data through the role plays that they had us practice. This moves us into the next part of our timeline, which is how to select those target behaviors. You're going to have some, you possibly will have some from probation or DCS, but you'll certainly be hearing about it from the parent as well. So we want to move into our step 2, which is formulating those target behaviors in collaboration with the parent, if at all possible. To do so, you're going to obviously look at the treatment planning goal worksheet, which is just a blank goal worksheet to talk about vision, about their hopes for the future, but to talk about their goals as well. You can also, and it's strongly recommended, to use the Triple P general basic format for goals. This is straight from their material, transferred in, and when you select Triple P standard or teen, it will autofill some of these. When you're doing these things, it's going to be divided into 3 basic categories, and these are the last sub-goals on the template of Triple P. The first is those desirable behaviors. That is behaviors that already are in place that the parent wants to see increase. You might say something like encourage desirable behaviors such as, and you put in what it is the parent wants to see increase that's already there. You also have new behaviors, which is a sub-goal, and that might be teach new skills and behaviors such as, so if we go back to the case of John and his children, he really wanted to see them start eating foods that weren't high in sodium. They were used to eating hot dogs and other things, and he was trying to introduce healthy foods like vegetables, but he didn't know how to do that. And we'll see some of what was throughout the course of this training, what might have been in the way as an obstacle. We might ask questions here in each of these categories as how much are they happening, or what is their impact upon the family. The third one is the challenging behaviors, and I save that to last because Triple P does as well. Triple P wants the family to build positive relationships before managing the challenging behaviors. And then in doing so, we can say something like, we are going to manage challenging behaviors such as, or we might say, reducing X behavior by such and such many times. So that might be some ways that we could word that on our treatment plan, and carry that over into working with the family and what they're to track. This moves us on to the next step of our timeline. And so if you look at our timeline, we have the targeting the behaviors first, and then we're going to move possibly into the teacher interview. So the teacher interview form is in your data summary book, and it is to be done after that parent interview. It is basically designed with a few items that you're looking at. You are looking at the general, you're going to ask the teacher about the adjustment of the child, behaviors happening inside the classroom or out on the playground, academics, their peer interactions, and any assistance that they've obtained up to date. Now, the recommendation from Triple P is to do a teacher interview if a youth is involved. It's suggested if a child, if it's a child that's if it's a child versus a youth, and then I would also suggest and recommend that if educational neglect is the reason for referral, doing a teacher interview is almost a must. A couple tips in doing a teacher interview is first, of course, obtain permission from the parent with an exchange of information form. Next, check in with the front desk upon arrival to the school. And third, respect the teacher's time. That's it. Moving on next in our timeline to the next step, which is probably the biggest one, and that is our assessment booklets or our assessment instruments. And specifically, that is step number 4. We begin with the child assessment booklet, which looks something similar to this. And the child assessment booklet, it has one assessment instrument in it, and that is the Strengths Difficulties Questionnaire. Opening the child assessment booklet, you'll find something like this. Now, the assessments, most of them are color-coded, so you can see green, blue, yellow, red, purple. These all are a different subscale for the Strengths Difficulties Questionnaire. The Strengths Difficulties Questionnaires' purpose is to target emotional, conduct, hyperactivity, peer relationship, child-adolescent problems. It is a brief screening that is designed for ages 2 through 17. So you'll find this also in the youth one, but with a little different wording on some of the items. The format is 5 different scales, and those scales look at emotional problems, conduct problems, hyperactivity and attention, peer relationship problems, and pro-social behavior. And then finally, over all of those, what is the impact of these actual problems that's happening within the home? It's easy to defend the Strengths Difficulties Questionnaire if you were called into court. It is rated an A on the California Evidence-Based Clearinghouse and has 2 or more published peer-reviewed studies that show the psychometrics are valid. This is an assessment that the parents are to complete on each child. So you'll want to grab a child booklet for each child within that family when you go out to the home. In delivering it, you want to discuss confidentiality, but then also read the items at the top, which says, for each item, please mark the box for not true, somewhat true, or certainly true. It would help us if you answered all items as best you can, even if you're not absolutely certain. Please give us your answers on the basis of your child's behavior over the last 6 months. For today, we're going to look at how to score this as well now. I should say that the time frame can be changed to the last month, and that might be helpful in looking at your work with the family and with specifically through Triple P. In decoding this today, we're going to go back to the story of John and his two children, Faith, who's 3, and Mark, who is 2. We'll score this according to what he scored his children. So we're going to turn to the scoring page in addition to the child booklet. The scoring page is within the data summary book 1 or 2. You can go and find this as well. So having these two open alongside of this training might be helpful as well. We're going to look at the different subscales and how to score those. Some of the items have reverse scoring. I'll make sure I mark those and show you how to do those, so you can come back to this video in the future. The emotional problems subscale is this yellow scale. So all questions that are yellow within this SDQ will transfer to this as well. We're going to put the children's initials at the top. You can see that there's up to 4 different sections for 4 different children. We had, in the previous way things were working, it was just complicated on how to track each child. And so we tried to simplify this process through this new delivery system. So turning to John's answers, this is some of his answers for one of the children. We're going to pull those answers from here. Now also notice that this one is in yellow. This is an emotional question, often complains of headaches, stomach aches, or sickness. So we're going to transfer this over to the other in the data summary. This is similar to how you would score it. So not true for left anchored, and I'll get to what that means, but left anchored is going to be a 0, somewhat true is a 1, and then certainly true is a 2. So we're going to go back to the subscale, and you can see here that we're going to transfer those in for Faith. Then we're going to total those and put that total at the bottom. We're going to do the same for Mark. And we're going to total those and put those at the bottom. So we have a 3 and a 4 so far on emotional problems subscale. All of these are left anchored. That's why it says 3-L, which is question 3, and left is start at the left, which is a 0. The conduct subscale is in red. And you can see that some of these items say -R. One of these items says -R. We're going to transfer the scores in, but notice this -R here. What does that mean? That means that it's right anchored. So we go back here and we look at that question. Here's question 7. Generally well behaved, usually does what adults request. Technically, we want that reverse scored. So we're going to put in a 0 at certainly true, a 1 for somewhat true, and a 2 for not true. That is what the R means on the number 7-R. We start from the right side, or it's called a right anchor. We go on to our next subscale on the data summary, which is the hyperactivity problems subscale. We're going to put in the children's scores for that, and then we're going to put in the totals. But before we do, notice that 2 of these items are also right anchored, and we're going to pull those backwards, like I've said under the conduct one. Then we're going to score and tally those. We already can see that Faith is as high as she can be on hyperactivity scale at a 10. Then we're going to turn to the peer problems, and it's kind of this different color here that you can see. And we're going to put in their scores, but in doing so, make sure you note there are 2 items that are right anchored. Next, at the bottom of the data summary sheet, you will see something like this. This is the total difficulties score. and it gives you an overarching score of how many difficulties are happening. You're going to put in the children, 1, 2, 3, 4 children or teen. So for child 1, you're going to total up the emotional, conduct, hyperactivity, and peer totals. Combine them together. So we do that for Faith and Mark. Faith is at a 20. Mark, who's only age 2, he's at a 15. Then we're going to turn towards the next one, which is a green scale called the pro-social subscale. All of these are left anchored, which makes it easy. We'll transfer those in and then total those. And then finally, we have the total impact subscale, which is the impact upon the household and the family. You can see difficulties, upset, distress, interfere with home life. All these are pulled from the back page of the SDQ or the second page of the SDQ. We're going to transfer in those scores. How do we get those scores? Let me show you. This is the back page, and this is an example of some of those scores. And here's where we're pulling those scores. It's this top question and then those 4 underneath. The other questions, the SDQ is not taking into consideration. So in this case, not at all is a 0, only a little is a 0, and then a medium amount is a 1, and a great deal is a 2. So you notice we pulled these, and that's a 1 plus a 1, which is a 2. Next, I want you to turn to the very back couple pages of the data summary booklet, either 1 or 2. And you'll find something that's called basically a data summary sheet. And there's divided into different categories. The SDQ falls under the child-teen behavior category. As we go throughout today's training, you will see that some measures fall under different categories. We're going to transfer all of the subscales from the SDQ into this section and put the children's initials. And this is why this is such a helpful page, or this booklet is so helpful, I should say, to submit to DCS or to probation. Notice here, now that we've put the scores in, on the right are clinical cutoff scores that are equal to or greater than for most of these, except for the pro-social. We don't want to see equal to or less than a 5 for ages 2 through 4. In this case, the family under pro-social, the green section at the bottom, are a 6, so they are not at a clinical level. But everything else has been marked because one or both children are at a clinical level. Let me take you through it. The total difficulties cutoff is 16. Faith is at that cutoff. Emotional problems, Mark is at that cutoff. Conduct problems, Mark is at that cutoff, which is, again, equal to or greater than 5. Hyperactivity, Faith is at a clinical level, maxing out at a 10, which means we may want to have further testing for the potential presence of ADHD. Peer problems, we see Faith is having some peer problems. And then the impact upon the home is at a clinical cutoff where it is clinically significantly impacting this family through the course of care. What do these different subscales mean? Let's go through a couple of them and I'll show you in the interpretation of these. The emotional subscale really is related to the presence of depression, worry, fear, nervousness, and even somatic symptoms in children and adolescents. Higher scores in this area have been related in research to the development of depression in adults. The conduct problems characteristics, generally parents score over time, parent scores in this section generally over time become better without help seeking. But if the teacher's scores over time worsen, though, the parents would seek help. This is related to prenatal in the research, it's related to prenatal anti-epileptic exposure as well with this one. Also to be noted that this is connected with children born preterm having higher rates of inattention, impulsivity, and even hyperactivity, even without a full diagnosis of ADHD. Which leads us on to hyperactivity. For hyperactivity, this one pediatricians do connect directly, according to a researcher named Riglin in 2021. Pediatricians are using the SDQ as a potential measure for the presence of ADHD, and then if they do score high, the children are clinically significant in their scores on this. Pediatricians generally will do further testing for ADHD. And then our next one would be the peer problems and prosocial considerations. For peer problems, the subscale has been shown to have probably the lowest reliability. And then definitely research has shown that the peer problems and prosocial subscales are connected somehow through that. In discussing this with families, thinking through how some questions that you might actually ask of a family, and I don't have them listed here, but you could always write these down if these might be helpful in discussing the results with the family. What subscales did the child excel in interpreting the scores? What subscales was the child rated as clinical? Do the results align with the parent's report found in the parent interview? What might the clinician look for in the interaction observation? So when we do that observation of the parent-child interaction or the parent-youth interaction, what might we want to look for in connection with these results? Because again, that interview observation or that interaction observation is us looking to see the data that we found in these measures, is it valid? Do we see it playing out in front of us? And then, of course, with some of these, do we need to have a referral to a pediatrician for further testing? And that wraps us up with the Strengths Difficulties Questionnaire and the parent booklet overall. Next, please pull out the teen booklet, and this is again for ages 11 to 17. The Strengths Difficulties Questionnaire is within the teen booklet, but we're going to skip over that. It's measured the exact same. We're going to look at the issues checklist. The issues checklist is not a new form to Triple P, but it is a new form for our teams. The issues checklist is just a brief overview of what's happening within the family. Its purpose is really it targets specific disputes and measures the intensity of the issues that's happening within the home. The general format or design is that there is an assessment, one for the adolescent on the parent. There's one for the parent on the adolescent. There's 44 items or questions, and it's meant primarily as a clinical tool for discussion. In defense of this measure, it has successfully discriminated between distressed families, i.e. those referred for treatment, and non-distressed families, i.e. those with no history of treatment and or self-reports of satisfactory relationships, according to Robin and Foster in 1989's research. Guidelines for delivery, really, it's both parents and the adolescent should complete this questionnaire independently. And at a minimum, at least one parent and the adolescent should complete this questionnaire. And again, I can't stress enough, youth and parents are not to see each other's responses. And we'll have another assessment under the adolescent section that's going to be very similar. If you look at the assessment, at the top is the script that you will read to the family. And that script says something like the following. Below is a list of things that sometimes get talked about at a home. Check yes for the topics that you and your teen have talked about at all during the last 4 weeks. Check no for those that have not come up. For the topics you have checked yes, please indicate how the discussions went, rating from 1 calm to 5 angry. Then in scoring, you're going to turn to your data summary and look up this box that says IC or issues checklist scoring to be able to decode it. 2 common errors that are found in scoring and decoding is number 1, failing to provide ratings for an item endorsed as yes. So making sure that the family marked the 1 through 5 as yes, for anything that they marked yes. The other one is people writing in, your parents or adolescents writing in words such as few or often. So if those errors occur, you may have to rerun this assessment. In scoring, you're going to take a look at the assessment, and you see at the top in blue it says yes or no. You are simply going to count the number of yeses, which is the quality of issues. And then to measure the intensity, you're going to add up all of the numbers to the right for everything that was marked yes. And it can also be helpful to compare areas where the adolescent and the parent ratings do not agree. So let me show you. In this section, we're adding up all of the yeses for this fictitious form that I created because John's story doesn't have adolescents. And then you're going to come over to your data summary sheet and you're going to put in on the data summary the number of yeses for the parent on the teen and then the teen on the parent for each adolescent up top. So you see Faith if they were an adolescent or Mark if they were adolescent as well. Then to get the total of numbers circled, you're going to go back here and you're going to look at the 1 through 5s for the yeses and tally those up. So right here we see a 4 and a 3. We'll tally those up with the others that are more below. We'll go back to our data summary and we're going to put in those numbers. All right. So going back to our data summary, we're going to put in those numbers. So for Faith, it was a parent on the teen was a 10 in intensity, on the total number of circled, and then the teen on the parent was a 4. Then we're going to take the total circled and we're going to divide it by the number of yeses. So the 10 divided by the 4 is the intensity. And I apologize, I think I said intensity earlier was the number circled, but no, it's not. The intensity is that the total of numbers circled, a 10, divided by 4 on Faith, parent on teen, which is a 2.5. We're going to do that for each one of these to get that tally. Then we're going to go to the last couple pages of your data summary booklet. And underneath that, you're going to see the IC issues checklist, and you're going to transfer those scores underneath. And in this case, it was just a father that completed that. If the mother completed it, then we would have those scores as well. And you can see that the total clinical cutoff is 2. So in this case, we do have some significant things that are happening with the issues within the home. How to discuss the issues checklist. It's meant to be a discussion. And here's some questions you might think through. You could bring this into the child-youth interview to incite discussion, Triple P says. Some of the differences. I wouldn't bring the actual form in, but it could, especially with the youth, incite discussion if you have a youth who's just sitting there not wanting to answer any of the questions. You must balance the rapport, though, if you were to do this. And then again, do not show the items to the other party in the discussion section here. And then this leads us to our next questionnaire or measure that is very similar to the issues checklist, but goes a little deeper into conflict. And that is the conflict behavior questionnaire. The conflict behavior questionnaire really is designed to target the communication and the conflict behavior. That is simply what it is doing. It's looking at what's the communication, what's the conflict behavior that's happening within the home. The design or the format is it's 2 adolescent on the father and mother measures. There's 2 father and mother on the adolescent measures, just like the issues checklist. There's 20 items or questions each for each of these, for each person that's completing it. It is best used as one indicator of the level of distress that the family members experience in their interactions with each other. It's an instrument that's best used in conjunction with the parent interview, according to the research, and also in conjunction with observable measures of interactional behavior. Thus, Triple P has the parent-child interaction or parent-youth interaction form and process that we're going to go through. In defending the CBQ, it has been shown in research to have adequate internal consistency, and it has been measured alongside other instruments for its validity. Now moving on to the delivery. There are some specific guidelines in delivering this, similar to the issues checklist. The first is both parents and the adolescent should complete this questionnaire independently. At a minimum, at least one parent and the adolescent should complete the questionnaire. Again, youth and parents are not to see each other's responses. And for this one, the timeline can be changed downward, according to research, to 1 week instead of 2. The script for this is something of the following. Think back over the last 2 weeks at home. The statements below have to do with you and your teenager. Read the statement and then decide if you believe the statement is true. If it is true, check the box marked true. And if you believe the statement is not true, check the box marked false. For each item, please check either true or false, but never both for the same item. Answer for yourself without talking it over with your partner. In decoding the CBQ, higher scores on this measure indicate negative perceptions, which are indicative of higher rates of conflict. The caution here is that individual responses have never been compared in the research with their behavioral equivalents, meaning inferring that individual items are connected with specific behaviors may not work. So you can't say like this is connected with this. It may not work in doing that. You're basically looking at overall what's happening in the decoding of this CBQ. You're going to turn to the scoring section as you see here to be able to decode this. And this is fairly straightforward. You have red items, which are false, and you have green items, which would be true. And this is how you might score this with someone. So we're going to put in Faith and Mark's answers from the father. We can see he's marked some false. He's marked, and the adolescents on him have marked some that are true. And you see that the adolescents' scoring is not the exact same order of questions as the parents. We'll go down to the bottom part of this, and you can see here, we'll put in their answers, and then we're going to tally up all of those. So if 9 has been marked false, then that's a check mark. If 19 is marked true, then that's a check mark. And then we're going to go down to the bottom and we're going to tally up all the check marks and that as 1 point. And so we do that for both sides and we tally that up. And then simply with the CBQ, you're going to go to your data summary and where the issues checklist was listed. You see the CBQ, it's very similar. You're going to transfer those scores in and then check the clinical cutoffs. At this case, we see Faith is above the clinical cutoff, parent on teenager, and then we don't see really any others that are marked at a clinical cutoff. In discussing the conflict behavior questionnaire, the guidelines may be, it might be good to look at the discrepancies between the adolescent and parent items. And again, you don't want to show the answers of the parents to the adolescent or vice versa. This moves us on to our parenting scale. The parenting scale is found in your parent booklet. Feel free to pause and turn to that to look at the parenting scale. The parenting scale is color-coded, similar to other assessments, with some colors not actually being scored, but primarily 3 different colors in there. The target or the overall purpose of the parenting scale is to target dysfunctional parental discipline practices. The parenting scale consists of 30 items, each one a scale of 1 to 7, and there are 3 stable factors of dysfunctional discipline style that are identified. Those are laxness, overreactivity, and hostility. In early trials of this, it was just laxness and overreactivity, almost as if they were polar opposites. Hostility questions, 3 of them, were added later. I would say if they scored anything on hostility, it may be good to follow up with questions about that, or running a conflict tactics scale parent-child. In defense of the parenting scale, it's easy to defend. It is rated by the California Evidence-Based Clearinghouse as an A, psychometrics well demonstrated. Certain research says the parenting scale exhibited adequate internal consistency and test-retest reliability. Mothers of clinical children reported more dysfunctional parenting than did mothers of non-clinical children, that is, clinical children within this scale. And then parenting scale scores were related to maternal ratings of child behavior and marital discord. And most important, the parenting scale scores correlated significantly with observational measures of dysfunctional discipline and child misbehavior. In delivering this, we would suggest not disclosing what the items are and what they're connected with, the subscales, as with most assessments. Obviously, continuing to keep things confidential, but also letting the family know, like every assessment, if it's going to be reported or easily accessed by DCS or probation. This is a scale that the parent completes on him or herself, as most of these within here are. The script is rather lengthy, but as with every assessment, don't want to skip it. At one time or another, all children misbehave or do things that could be harmful, that are wrong, or that parents don't like. Examples include hitting someone, whining, throwing food, forgetting homework, not picking up toys, lying, having a tantrum, refusing to go to bed, wanting a cookie before dinner, running into the street, arguing back, coming home late. Parents have many different ways or styles of dealing with these types of problems. Below are items that describe some styles of parenting. For each item, circle the number that best describes your style of parenting during the past 2 months with your child. When it comes to this parenting scale, John himself filled this out as well, and we will look again at his results that he rated himself in his parenting style with his children. We will look at the scoring page that's within your data summary booklet, and you can see the 3 subscales: laxness, overreactivity, hostility, and then there's a 4th considered no factor. This doesn't mean how they use the word no, though some of these do have to do with the word no. This just simply means they're not considered, but they are used for scoring purposes, for decoding the scoring. Now, if we look at the scores, here's what John had written, some of the checks that he had done on his parenting scale. And again, like the other scales that we've looked at, some are left, which start at number 1 and go up to number 7, and some are right anchored, which start at 7 and go down to number 1. So you would count those backwards. Our first subscale is the laxness scale. And so looking at laxness, we want to, and overreactivity, we'll look at those, and you can see the ones that have a -R, which are right anchored. We will pull in those results from the father, and then we're going to sum that, and then for this scale we're going to divide by 5 and we get 3.14. We're going to do the same for overreactivity. We're going to look at his results and transfer those over, those numbers, and then we're going to sum it up and then divide by 5 to receive a 1.4. Hostility and no factor are the other two. We're going to do the same. Hostility is only 3 questions, and he rated himself a 1, which is the lowest that it can be. We'll sum those up, and then for this one, divide by 3 the 3 items that are there to receive the average of 1. No factor is a little different. We're going to transfer those over and then tally those up. And then further down, for totaling and total scale score, we're going to add all of the scores together, laxness, overreactivity, hostility, and no factor for each of the parents, and put the score there. In the case of John, he received a 91. Then we're going to take the total and divide by 30, which is the number of items in the entire parenting scale, 3.03. Next, similar to our other measures, we're going to turn to the last couple pages of the data summary booklet and look for PS, or parenting scale. And you can see here we have our spots to put the scores in: the total, the laxness, the overactivity, and hostility. We'll transfer those over from John. And this is one of the scales that we use to measure outcomes whenever Triple P is used. So laxness, overreactivity, hostility, and total will also be put into our database for tracking, so that when we do this set of measures again at the end of our time with the family, especially when Triple P is done, we can see if the family made progress. Lower scores are better. Higher scores means more laxness, more overreactivity, or more hostility. We're going to look to see now if anything is clinical for fathers. A score equaling or greater than 3.4 is at a clinical level. So we can see for this father that laxness is involved with this case. And in my own observations in working with this case, I also noticed behaviors that would contribute towards laxness. Characteristics of laxness, if we were to say what happens with parents who score high in this, they may have these characteristics: a lack of consistency in their parenting and their discipline techniques. They may have ineffective limit setting, and this also may be related to oppositional behavior and conduct disorder per the research that's out there. The primary characteristic of high scores of laxness is a parent who is permissive and inconsistent when providing discipline. When it comes to overreactivity, these areas may be there. An authoritarian style of parenting. They may be harsh and include threats. So if you look at some of the items, it does include some of that. And it can be connected or related to antisocial teen behavior. The overarching primary characteristic of this high score would be a parent who is coercive when providing discipline, according to the Triple P book itself. And then our last one would be hostility. And parents who score high on this would use insults, cursing, and or corporal punishment when providing discipline. Again, using the parent-child conflict tactics scale may be helpful to flesh out what specifically is being used in that. The parenting scale pulls out these three questions for hostility from the overreactivity scale, just to build awareness. As we wrap up with discussion, some of the thoughts here might be having your originals on hand, the original items that were marked in case you're questioned by the parent. And you could say something like "you've indicated," or you could say "compared to the general population," and you want to work towards a collaboration on discussion of these results with the parent. Again, I'm going to defer you to the Triple P training, especially as related to the exam and the role plays for the exam for discussion of results, especially important for the parenting scale itself. This moves us on to discussion about the Relational Quality Index, or the RQI. The RQI is a very basic, straightforward, easy to score form that really its whole purpose is to target the quality of the relationship. The format or design is set up with 6 different items at a 7-point Likert scale, which are assessing the relationships of married, and it can assess the relationships of cohabitating couples as well. In defending the RQI, research shows that the validity says the authors reported that the Pearson correlation coefficients between QMI and DAS were between 0.85 and 0.9, and that the Pearson correlation coefficients between the QMI and the RSAT are between 0.87 and 0.94. That's by the Early Intervention Foundation in 2020. Looking at multiple different assessments to see is there validity between them and what it's looking at. Reliability, from my review of the evidence, I did not find any articles talking about the test-retest reliability of the RQI. In delivering the RQI, it is to be taken by one or both parties. You can have one person who does this of themselves and their a significant other. The script is very basic and straightforward. Says, circle the number that best describes the degree of satisfaction you feel in various areas of your relationship with your partner. In decoding the RQI, as I said, it is very straightforward. You're going to add all the numbers that were given for mother, and then separate assessment for father, and you're going to tally those questions together. Now, those questions only involve questions 1 through 5. 6 is not included on this assessment. And then you're going to start out with number 1, very strongly disagree, it's still a 1, to number 7, very strongly agree. You're going to pull then out your data summary and go to the very last couple pages under partner support, and you're going to drop that number in, and note the clinical cutoff is equal to 29 or less. So we want to see higher numbers are more positive or better. Lower numbers means less happening in that relationship as to the quality of that relationship. In discussing the RQI, you might ask where would they like to be in their relationship, and how might increased satisfaction in their relationship help with parenting. This moves us on to one of our final measures, which is the DAS. The DAS is very short. It can be considered a clinical assessment as well, but Triple P uses this and says that pretty much anybody, if they're trained, can use this. Overall, the purpose of the DAS is to target core symptoms of depression, anxiety, and stress. The format or design is 21 items, 3 subscales, which include depression, anxiety, and stress. And this is designed to remove the overlap between depression, anxiety, and stress that we do see when we're out in the world. In defending the DAS has demonstrated positive psychometric properties in adult samples of anxiety and depression patients and student samples, according to the Journal of Affective Disorders. It must be recognized, though, that clinically depressed, anxious, or stressed persons may well manifest additional symptoms that tend to be common to 2 or 3 or all 3 of the conditions, such as sleep, appetite, and sexual disturbances. These disturbances will be elicited by clinical exam, though, so you have to ask further questions, and likely a therapist needs to be asking those questions. Or you could use like a general symptom checklist. The DAS had good internal reliability, and its ordinal alpha demonstrated good internal reliability for all its subscales. As to reliability, for depression, it is scored in at a 0.91, anxiety 0.84, stress 0.9. So it is, according to all the research, it is very reliable and a very valid score. As to the DAS, this is to be taken by the parent of him or herself, not of others. And the script reads something similar to, please read each statement and circle a number 0 to 3, which indicates how much the statement applied to you over the past week. There are no right or wrong answers. Do not spend too much time on any statement. And then it'll give the rating scale. In decoding the DAS, there's a couple notes. The first is it can be administered and scored by non-psychologists, but decisions based on particular score profiles should be made by experienced clinicians. Note this too, that none of the DAS items refers to suicidal tendencies, because items relating to such tendencies were not found to load on any scale. But experienced clinicians can recognize the need for further assessment, and you may want to pull out like a Beck suicide scale or something along those lines. The DAS is designed to emphasize states rather than traits. Now, as we go through the scoring, we're going to look at fictitious scores here. This was not done with our family, John, but you will look at the DAS and pull in those depression scale scores and drop those in from the different items. And then you're going to sum those up and then divide, or times, I should say, by 2, not divide like the parenting scale. You're going to times it. Anxiety, same. Transfer them over. And then you're going to put in that score and then times it by 2. And then the same goes for the stress. You're going to add those and then times it by 2. So we can see that this client here, whoever he or she may be, has quite a bit of stress. It'll be interesting to see if that loads as on a clinical scale level. Then we're going to tally those up. So we're going to add the bottom totals, depression, anxiety, stress, combined totals equals 36 in this case. And again, if I went back to this, you're gonna score it similar to how it looks. The numbers are already on there, 0, 1, 2, and 3 for each one. So you're scoring front. You're gonna turn to your data summary sheet at the back of it and look at parent adjustment. And here we have the total, depression, anxiety, and stress. We're gonna transfer those scores to here so DCS can easily access those. Then we want to look at the clinical cutoffs and compare. We can see the clinical cutoff is equal to or greater than 19. So we're safe. We're at 18, but we were close. The characteristics of each of these are many, and I want to spend some time going through what those look like for you. Those who score high on the depression scale have the following characteristics. They may tend towards being self-disparaging, dispirited, convinced that life has no meaning or value, pessimistic about the future, unable to experience enjoyment or satisfaction, unable to become interested or involved, and slow, lacking in initiative. Stop and think a minute how that may impact your case and the overall success or unsuccess of your case. Here's some of those others that I just mentioned. When it comes to overall, for depression, the principal characteristic is a loss of self-esteem and incentive, and associated with a very low perceived probability of attaining personal life goals of significance to the individual. It'd be very hard to complete those goals. When it comes to anxiety, some of the characteristics may include a client who is apprehensive or panicky, trembly, shaky, aware of dryness of the mouth, or aware of their breathing, difficulties of pounding of the heart, sweatiness of the palms, or worried about performance and possible loss of control. What is the difference, though, of fear versus anxiety? The research here shows that fear is a response to immediate threat of harm, whereas The anxiety involves longer term anticipation of negative events, which typically, but not exclusively, are psychological in nature. When it comes to the development of anxiety, we're looking at someone facing performance demands of self-esteem importance, has low self-esteem and or high self-imposed performance demands, someone possibly perceiving the probability of failure to be high, holding a low threshold of activation of the fear system, and caused as a consequence of continuing physical threat. It can be. Anxiety can be. When it comes to stress characteristics, we're looking at some of the following of those who score high clinically: over-aroused, tense, unable to relax, touchy, irritable, easily startled, nervy, jumpy, fidgety, intolerant of interruption, or intolerant of delay. With stress, one of the principal characteristics here is a persistent state of over-arousal, which reflects continuing difficulty in meeting taxing life demands. So it's slightly different from the anxiety that we just discussed as well. In discussing these results, it may be good to look at what do the results look like in the home when it comes to the interactions between family members, especially when it comes to the interactions with the parent. When might these results come out more? Are there certain circumstances that might make it worse for the parent? And how might the parent want this to look in their life 6 months from now? One of those solution-focused questions that we can ask in probably any of these, but certainly when it comes to depression, anxiety, and stress. This leads us back to our timeline to part 5. Which is our child and or youth teen interview. The child teen interview is also within your data summary booklet, which is what we submit to DCS. The child teen interview really has to do with the following. Again, as I said, it's optional. The teen interview is especially important in cases of probation, but looking to balance that rapport when you're doing this teen interview. And having the teens sign paperwork, I will just add in, when they're involved in a case is also helpful. The child-teen interview is 1 page. It looks at the child's views of the problem. It looks at other concerns the child or the youth may have. It looks at what the child thinks is happening with their relationships, especially with friends, and what the child's views are of what's happening at school and in the issues they may have at school. A few do's would be gain the parent's permission before interviewing, set up the interview guidelines beforehand, consider the child-youth's age and development, ask open-ended questions, and use the issues checklist as needed with youth to get conversation happening. A couple don'ts would include don't choose a location filled with toys, art, or distractions if you can help it, and don't ask focus questions or use unknown words. Don't ask things like, did X person do Y action to you? Those are some things to stay away from as no-nos. That's it for the child interview. We move back to our timeline, and now we will look at one that is possibly more difficult for some, and that is the parent-child/teen interaction observation. As with the other forms, the parent-child observation is in the chart, and for our cases, it looks something like this. It's in the data summary booklet. It looks something like this. And for our sake, we're going to look at these different categories through the lens of John and an actual observation that took place with John during a mealtime. This doesn't have to be done at a mealtime. The interaction can be done at another time, but it does need to be scheduled and purposeful not just a normal session. So if we go back, you can see that there's excesses and there's deficits. Excesses would be those things that the parent is doing too much. And the deficits, it's the parent may not be doing enough. We're looking through this whole time, and I shouldn't say just parent, but the child, teen too. We're looking through this whole thing. What we're looking for is to test the data that we've collected from the interviews and from the measures to see, are we actually seeing these happen? In the case of John, we noticed that John addresses Faith's aggression during the interaction verbally, but no additional consequences. We also saw John during this time go through multiple foods to find what the child wanted to eat, to the point of going overboard with it. The grandmother was also involved, and she expressed dissatisfaction with the children of their behaviors right in front of them as related to the damage that she believes happened at the bio mother's home, which is a different home. And for excesses, we notice that Faith is using aggressive behavior and hitting the observer, in this case, which was me. We move over to the deficits. Neither parent, or I should say the parent or the grandmother, did not eat with the children, though one of their goals was to introduce new foods that were not high sodium. So they were not practicing that modeling before the kids, and they would eat at a different time. It was also noticed during this interaction observation that Faith showed difficulty making her needs known without using barely any words whatsoever. And it also noticed that the children only appeared to want to eat high sodium food. So when certain foods like hot dogs or SpaghettiOs, which were the two foods specifically mentioned by John that he did not want them to eat, when they were introduced, the children ate them. We move down to the bottom, and there's two new sections. There's assets, which are the strengths that are observed in the interactions that are happening. And then there's the possible factors maintaining the problem behavior. And then after that, there might be some suggestions for change. So as we look at the assets noticed in this specific interaction observation, we see both children having developed their pincher ability in eating, which is great to see. Mark, the 2-year-old, verbally and in body language requested food. Faith and Mark both ate their food that was presented to them. Not the first food, but the second or third time. John, he did show sensitivity to the needs of his children. He did not get upset. The grandmother and the father maintained emotional composure when Mark began attempting to throw food. We go down to possible factors here, and again, these are possibilities, hypotheses. There appears to be a struggle that exists with the father knowing how to attend to his child's needs in connection to lack of verbal response of Faith. The parents were eating separate from children at different times. Eating with the television on, distracting from interaction times. So the children, there was no table. The children were facing out of the kitchen towards a giant 90-inch TV that was on constantly during the whole entire visit. The father is attempting to find the balance of assertiveness and listening of the children's needs related to food, possibly increasing a laxness in his parenting style, which the parenting scale score that we saw was his results, which were higher at a clinical level of laxness. The father appears to be unsure at times how to engage his children. And then there's possible unfiltered aggression from certain cartoons coming out in Child's Play. Some of the things they had on TV were a little aggressive. And then our last section, as I said, would be suggestions for change. There's a few here, quite a few. Maybe eating at a table together, caregivers modeling, having moments of no TV, allowing boredom, no screens to increase ability to focus, verbally praising the children when talking as adults in front of them, using soft, gentle touch guidance, not showing sugary foods to the children until a meal is complete. Grandma came in halfway through the meal and brought in ice cream, brought it out and showed it, brandished it to the kids, and of course they didn't want to eat their food when they saw that ice cream. Practicing fairness of food. If one gets a banana, the other does too. The caregivers presented a banana to one of the children. The other child behind that child saw the banana and became upset that they didn't get one, but the caregivers did not realize that the child was getting upset because they didn't get a banana. Offering a hug to both children when leaving to work, even if they don't ask for it. interactional, purposeful play with the children, and reserving concerns of children's behavior when children are not present. So that is an example of an interaction observation. Yours will be different because every family is unique. Next, we move back to our timeline, and we're going to look at the data being confirmed with the supervisor. And simply, this is to meet with your supervisor to confirm the data collected, because sometimes we might get the scoring incorrect. And this is also time to do this before the parent-child observation might be helpful too. And this is also a time to brainstorm any potential areas of defensiveness and how to build parents' collaboration before you go in to present all of that data to the parent from the observation, from the measures, and everything else. This is the next step, which would be to present that data to the parent. And as said, following the Triple P format from the Triple P accreditation exams is recommended, and using the data summary sheet definitely will be helpful. Having the completed instruments, those booklets on hand, just in case the parents ask where you're getting that data, could be helpful as well. And then in wrap up, our last one is to update those target behaviors as you go through the case. There may be things that pop up that the parent initially did not want to tell you. And so it may be helpful to go back to the treatment plan monthly to say, how are we doing on these? Do you have any other thoughts and concerns? And of course, tracking those behaviors that the parent wants to see decrease and the parent wants to see increase is going to be helpful for you as well. As we conclude, I just wanted to point your attention to Google Drive. It's an app that you can download, and you can link it directly to the Triple P resources of family preservation. You can access the session summaries and use those on your phone during a session. You can access behavioral checklists and show a parent how to do that digitally. You can also access the behavioral contracts to show parents what that's looked like and how that's laid out. In addition to that, you can also pull up the videos for Triple P, and some of those videos are accessible. All of them are. The link is accessible within the session summary itself. You can click the link and open up those videos. The following are references that were used for this presentation, various ones for this presentation as well. If you have any questions after this, please don't hesitate. Reach out to your supervisor who can get that information for you. And again, practice, practice, practice. All right. Take care and have a great day.